Good morning, everyone. I hope everyone's having a good morning. For those that I haven't had the chance to meet, my name is V. Bui. I'm one of the ICU pharmacists at Hendrick Medical Center. Just a little bit of introduction about myself. I graduated from Texas Tech School of Pharmacy in 2016 and started working at Hendrick ever since. For the first 3 years of my career, I worked in the ED and was asked to move to the ICU as they were starting the intensivist program. I am honored to have this opportunity to work with you guys in the fellowship program, and I apologize for not being able to be here in person. So if you guys have any questions, don't hesitate to shoot me an email or talk to Paulita, and I'll try to get back to you guys as soon as I can. So for today, we'll be talking about different anticoagulants, antiplatelets, fibrinolytics, and at the very end, we'll touch on a little bit on strategies to reverse these agents in a bleeding patient. So just to give you guys an overview of how this lecture is laid out, we'll first identify and differentiate between the differences between all the anticoagulants, antiplatelets, and fibrinolytics. I have a few slides that are heavy on pharmacology, but I just want you guys to focus on being able to recognize and know which agent is which. So that will probably be about 60 to 70% of this lecture. Then we'll talk about dosing of fibrinolytics, especially tenecteplase, because that's the agent that we're using here for ischemic stroke. We'll do some practice problems as well to make sure that everyone is comfortable with the dosing. And of course, if you guys have any questions, you can always refer to your educator. You can always give me a call and I'll help you guys out. And I understand it can be kind of scary in the heat of the moment. Then finally, we'll quickly touch on the major reversal agents for a bleeding patient on blood thinners. We know this is a very common problem because I figured if we spend time to talk about all the blood thinners, it's probably helpful to talk about reversal strategies for these blood thinners as well. We keep talking about blood thinners this, blood thinners that. I just want to stress that calling all blood thinners is kind of a misconception. And while it is more familiar to patients to call their medication blood thinner, it is a misnomer since it implies that these agents work in similar fashions. And while it is true that they all increase the risk of bleeding and pose a really big challenge to manage a bleeding patient on these agents, but we also need to keep in mind that the different drug categories work differently. And a lot of time there are reasons why a patient would be on several different blood thinners, but they are definitely not duplications of therapy. So I just want to bring up the two misconceptions that all agents are from the same class with the same mechanism of action. And I've heard this before, that a patient is on Brilinta or Plavix, so the blood is already thinned and the patient should not be on additional chemical DVT or PE prophylaxis, which we'll talk about in a little bit, but it is a misconception as well. As I alluded to this earlier, antiplatelets are very different from anticoagulants, and conflating the two drug categories will lead to omission of necessary medications. A few examples that I could bring up is, so earlier we talked about how a patient who's on aspirin and Plavix, they still have high risk for VTE and in the inpatient setting, and as we all know, with our ICU patients, they are immobile, so the risk of VTE is actually really high. So we do need to have chemical prophylaxis on these patients, and this is definitely not a duplication of therapy. Another example would be a patient with chronic AFib, and then they got recent stents. And so this patient in particular will need both Eliquis, which is an anticoagulant that prevents the patient from having a clot from AFib, but at the same time, they also need the aspirin and Brilinda, for example, combo for a certain period of time. A lot of time they'll be on it for like at least a year. And yes, this type of patient has a really high risk for bleeding, considering the amount of medications that increase risk of bleeding. But it is not a duplication, and it is medically necessary for these patients. Although, for example, number 2, I do want to bring up that this one patient in particular will not need chemical VTE prophylaxis because Eliquis is already considered full anticoagulation. So in this case, both Eliquis and sub-Q heparin, for example, would be a duplicate. So all of that just to say that it is important to really look into their past medical history and current hospital course to determine appropriateness of all of these agents. If someone comes in with a history of AFib or VTE, then maybe we should be questioning to make sure that the patient is taking an anticoagulant. And if someone has a history of recent stents, then maybe they should be taking antiplatelets. So usually aspirin and in conjunction with another antiplatelet agent. And for the last point that I want to bring up is this happens a lot in the ED. For stroke codes, we don't usually come across a lot of that in the ICU, but when we evaluate a patient for fibrinolytics, aka tenecteplase and alteplase, for ischemic strokes, and interestingly, the one contraindication for fibrinolytic is current use of anticoagulants, but if a patient is on antiplatelets, they should still be included for evaluation of fibrinolytics. Okay, so this is just a quick self-knowledge test. I put on the slide a bunch of different anticoagulants and antiplatelets. Are you guys able to tell which one is which? I'll give you guys about 3 minutes to put either anticoagulant or antiplatelet next to the names of these medications. And on the next slide, we'll have the answers. And for your version of the slides, I put the answers at the very end of the lecture. So no peeking. All right, and 3 minutes starts now. Okay, how do we think we did? So for your version of the slides, the answer is going to be at the very end of your slide deck. Under anticoagulants, we have heparin, rivaroxaban, apixaban, enoxaparin, and warfarin. And under antiplatelets, we have prasugrel, ticagrelor, clopidogrel, and aspirin. And don't feel bad if you missed a few, because at the very end of this lecture, you'll be the master of it. Okay, so firstly, let's talk about anticoagulants. Anticoagulants are usually used for VTE treatment and prophylaxis. They are also used in patients with chronic atrial fibrillation for stroke prevention. And oftentimes we'll see them used in PCI, percutaneous coronary intervention, or a cath lab. And it gets a little murky here because a lot of times we see anticoagulants, but they are used for their antiplatelets properties. And I'll be sure to point that out when we talk about the different agents in a little bit. Another thing that I want to point out is that for a VTE type of dosing, there is a difference between a prophylaxis dose versus a full anticoagulation, quote unquote. And you'll notice that there are agents that can be used for both indications, and a lot of time the only difference is in dosage. It makes sense for VTE prophylaxis dosing to be a little lower than the full anticoagulation dosing, or sometimes the route can be different. In the case of heparin, sub-Q for prophylaxis and usually IV continuous infusion for the full anticoagulation. And another thing that I stress for my pharmacy students and everyone is that anticoagulations are not clot busters. They are used to stabilize and prevent further expansion of blood clots. So if we're starting a heparin drip, for example, for a patient with a PE, the heparin itself will not dissolve the existing blood clots. It is usually started immediately after diagnosis to prevent the blood clots from getting bigger. And in the meantime, we're allowing the body to dissolve the existing blood clots by itself. So a very important point to remember. Okay, you guys might have seen this in school and thought that you probably won't ever see it again. So I want to bring it up again, the coagulation cascade. One thing that always blows my mind is that the body always has these pathways that's very complicated to react to any kind of insult. And in this case, in response to a trauma or and some sort of insult in the vasculature, a whole cascade of what seems to be a million pathways happens. This activates that, and the newly activated thing will activate another thing, with the final purpose is to create a clot to prevent bleeding. And I don't expect you guys to know every single factors and every single steps in this cascade. I don't remember any of this myself, but just notice that all of these coagulation factors have a name, and this will clue us in later on how some of the anticoagulants work, because some work on certain factors and some others will work on other ones. And the end result is that platelets are activated, create a bunch of fibrins that will try to basically plug a hole on the blood vessel wall, preventing further bleeding. So here is our coagulation cascade again, but this time I added all the anticoagulants into this cascade. And just to show the different coagulation factors that they inhibit, you'll probably hear factor 10A being mentioned a lot, and it's because it's one of the vital coagulation factors that get inhibited by apixaban, by rivaroxaban, even heparin and enoxaparin also work on factor 10A. So it is the blue box in the middle of our slide. To Bigatran, the yellow circle works a little bit differently. It works on thrombin or factor 2A, and hence the name direct thrombin inhibitor. Warfarin is an older anticoagulant, and it works on a lot of different coagulation factors. So we got factor 7, 9, 10, 2, and it also inhibits proteins C and S. So the one special thing about proteins C and S is that they are the body's natural anticoagulants. So they do the opposite of creating a clot. And by inhibiting these proteins, warfarin actually increases clotting in the beginning phases. And so it is important to remember, because if we're trying to treat a patient with a VTE, for example, we need to bridge the patient on a parenteral anticoagulant with warfarin until INR is therapeutic. It's getting kind of busy with this slide, but I just want to give you guys a very detailed look over the different anticoagulants. So on this slide, we'll talk about parenteral agents, meaning IV and sub-Q agents. And on the next slide, we'll talk about oral anticoagulants. So we've got heparin, enoxaparin or Lovenox, fondaparinux or Arixtra, argatroban, and bivalirudin or Angiomax. So from the last slide, we talk about how heparin affects factor 2A and 10A, with 10A being our part of interest. And another thing to keep in mind is that it also inhibits platelet activation. And so a lot of time, this is why it is used a lot in cath lab setting. And I try to be simplistic with dosing here because it really depends on the indication. But for heparin, DVT prophylaxis type of dosing is usually sub-Q, typically 5,000 units twice a day or 3 times a day. When we're talking about full anticoagulation, it usually means it's an IV infusion. And at HMC, we have specific protocols for either VTE and ACS. One thing that I want you guys to keep in mind is that heparin is actually not a name of a drug molecule. It is an accumulation of tons of molecules that are similar, but they vary so much in size and form. That is why it tends to trigger immune response and causing, hits, heparin-induced thrombocytopenia, and we'll talk about hits in a little bit. Heparin is, as a DVT prophylaxis agent, it is preferred for patients with impaired kidney function. So for CKD and dialysis patients in the ICU, we prefer to use heparin over Lovenox for DVT prophylaxis. Monitoring wise, we use UFH, which is another name specifically for heparin, but it is another name for anti-10A. And it really just depends on the institution. Some institution will use PTT, APTT. In cardiac surgery, we have ACT as well. And you guys will probably see PTT, APTT monitoring for heparin here on some ancillary heparin protocols. But for our 2 big ones, VTE and ACS, we use UFH monitoring, which is another name for anti-10A. enoxaparin or Lovenox, it works very similarly to heparin, but it has a better, more specific activity against factor 10A. As far as dosing goes, VTE prophylaxis dosing is usually anywhere from 30 to 40 sub-Q daily. We do adjust it based off of BMI as well, but it gets kind of complicated. So pharmacists usually would just adjust it for you guys. When we're talking about full anticoagulant for Lovenox, it is usually 1 mg per kg sub-Q. So notice that for Lovenox, prophylaxis and full anticoagulation dosings use both sub-Q, whereas in heparin, prophylaxis dose is sub-Q and full anticoagulation is IV. It is considered a more purified form of heparin, meaning that those molecules are a little more similar in sizes, and so it has a lower risk of triggering immune response, causing HIT. But on the other hand, it is not recommended for patients with poor renal function. So with our dialysis patients, we try to avoid, because they tend to accumulate quite a bit of Lovenox, causing increased risk of bleeding. We don't typically monitor Lovenox, but we can with anti-10A level as well. Here we don't call it UFH, and we call it as anti-10A. At Hendrick, we have lab basically has different calibrations for heparin and Lovenox, and so we kind of have to specify whether it is UFH, which is anti-10A meant to be for heparin, and anti-10A that's meant to be for Lovenox. The third agent, you probably won't see this a lot. It is fondaparinux. It is also another factor 10A inhibitor, similar to heparin and Lovenox. It is also dosed subcutaneously, with prophylaxis dose being 2.5 milligram daily, and a full anticoagulation dosing is usually 5 to 10 milligram sub-Q daily, and that's usually weight-based. It is a synthetic form of heparin, and so it has the lowest risk for HIT, and a lot of time in patients with risk of HIT, we actually use fondaparinux. There's not a whole lot of monitoring required for fondaparinux. Argatroban is our IV form of a direct thrombin inhibitor, and it also inhibits platelet aggregation. So again, we'll see the utility of that in cath lab quite a bit as well. It is for full anticoagulation only, and for titration protocol, we do have a protocol here for you guys to follow. And one thing about argatroban that I want to point out is that there is 2 different starting doses on the protocol, with a dose reduction for patients with hepatic insufficiency, so our cirrhosis patient, liver failure patients. And we monitor and titrate based off of PTT. Finally, bivalirudin or Angiomax. We almost see this exclusively in the cath lab due to its platelet activation inhibition. It is also a direct thrombin inhibitor, and so this is where we see the double anticoagulant and antiplatelet kind of activities for heparin, argatroban, and bivalirudin. It is a continuous IV infusion with a small bolus and then a flat rate. It has a pretty short half-life of about 30 minutes or so, and so a lot of time you might see being preferred in cath lab for patients with a lot higher risk of bleeding, and it is also preferred for patients with a history of HIT. In cardiac surgery, the monitoring lab for it is ACT, and since it's a point of care kind of testing, when they're in the ICU, if for whatever reason they're on bivalirudin, we'll monitor by PTT. And I just want to point out one thing is that these monitoring labs are just specifically to the medication, and of course for patients who are on any kind of anticoagulation, we'll have to monitor for signs and symptoms of bleeding and H&H, things like that. And I didn't want to include all of that in the slide to make it even more busy. All right, we're getting through our anticoagulants. I promise this is the last slide for anticoagulation. So these are the PO options for anticoagulants. We have Eliquis, Xarelto. They work the same way. They're just different manufacturers, different drugs from different companies. And then we have the older agents, warfarin and dabigatran. For apixaban, again, it is an anti-factor 10A. The dosing for VTE and AFib are similar, but one thing that I have to point out is that for specifically VTE, so DVT and PE indication, there is a loading period where the patient would have to take 10 milligram twice a day for 7 days, and then we drop down to the usual 5 milligram twice a day. For AFib indication, we don't have to do that weird dosing for the first 7 days. We can just start them at 5 milligram twice a day. Some patients' population, body weight, or elderly, or patients with impaired kidney functions, we do have a dose reduction to 2.5 milligram twice a day. Of the two anti-10A inhibitors, Eliquis and Xarelto. Eliquis is recommended in patients with renal issues, so your CKD, HT patients. Xarelto works the exact same way. For VTE dosing, similar to Eliquis, we need 21 days of the 15 milligram twice a day dosing, and then we can drop to 20 milligram daily dosing. AFib, again, we can start at 20 milligram daily without the loading period. It is not the best for patients on dialysis. As far as monitoring, they are technically factor 10A inhibitors, so it only makes sense that we should be able to monitor anti-10A levels with these. However, there are not, the tests for these oral agents are not calibrated in the lab, and so you can technically send a level, but whatever they give you wouldn't tell us anything other than whether the patient is actively having an anti-10A agent in their system. Like, the number won't tell us anything. And same for INR. Oftentimes you see patients coming in with a bleed and they are on one of these agents and they have elevated INR. What does that mean? It doesn't mean anything. And so unlike warfarin, where we do titrate to a specific INR, and in a bleeding patient, we treat them to a specific INR, Eliquis and Xarelto will just elevate the INR without telling us any meaningful information about this INR number. So we don't treat to an INR. Warfarin, like we mentioned before, in the coagulation cascade, it inhibits a lot of different coagulation factors. including protein CNS. And so for a new patient on warfarin, we usually start them on about 2.5, 5 milligram PO daily, and we just kind of titrate, every few days based off of INR. On the outpatient setting, chronic warfarin regimens are usually titrated based off of like their total weekly dosing. And like I mentioned before, sometimes we need to bridge a patient with on warfarin with Lovenox or heparin. So basically a parenteral agent before they get to therapeutic INR. There are a lot of interactions between warfarin and other drugs, warfarin and food, like we were all taught in school. And so the question is, why is warfarin even used nowadays that we have, better agents that are easier to manage, with fixed dosing like Eliquis and Xarelto? Well, unfortunately, warfarin is the only oral agent that is approved for mechanical valves because back in the day, they tried to do a trial between Pradaxa or dabigatran and warfarin in mechanical valve patients, and unfortunately, they found a higher incidence of death, so higher mortality for Pradaxa versus warfarin. And so these newer companies who made apixaban and rivaroxaban, they don't even bother with those studies anymore. And so our typical INR range for a patient on warfarin is usually 2 and 3, unless they have, mechanical valves. Mitral valve usually is 2.5 to 3.5. And lastly, kind of an honorary mention for dabigatran. It is a direct thrombin inhibitor, so another oral anticoagulant. The typical dose is 150 milligram twice a day. It is, like I said, older. There are a lot of other preferred agents like Eliquis and Xarelto, and so we don't really see patients on Pradaxa a whole lot anymore. But it's also important to know that it exists and there are older patients who might be on it. So that concluded our section about anticoagulants. Before we move on to antiplatelets, I would like to touch on a little bit about heparin-induced thrombocytopenia. It is a very rare condition where upon exposure to heparin, the body produces antibodies, and it can be potentially life-threatening. And some of the signs and symptoms for that are a drop in platelet count, skin necrosis, thrombosis. This typically develops over 5 to 10 days after exposure to heparin, or if a patient had a prior exposure or a prior admission where they received heparin products within the last 30 days. It can happen a lot quicker, so less than a day for those patients. And again, as I mentioned before, heparin has a significantly higher risk of causing HIT than more purified, more modern products like enoxaparin, Lovenox, etc. And the reason why I mention HIT type 2 versus type 1 is that type 1 is usually a transient drop in platelets when you start heparin. It doesn't go, the platelet count usually doesn't go very low, and it happens a lot quicker than 5 to 10 days. But our platelet counts usually recovers, and there's no ill effect from that. There are also other possible causes for thrombocytopenia, especially for an ICU patient. So we just have to be cognizant of other causes. Some medication, sepsis, CRRT, some invasive devices can cause platelet activations, and that in turn decreases platelet counts, but it doesn't mean that the patient has HIT. Again, it is life-threatening, but it is very rare. And oftentimes in the ICU, there are a lot of other plausible explanations for a decrease in platelet count. So just a few things to keep in mind before we send out all the workup labs for HIT. So as I mentioned before, it's a whole process to figure out whether a patient is having low platelets due to exposure to heparin versus something else that's going on. And so the 4T score was developed to help figuring out the probability of actual HIT. And as you can see over here on the very left hand column, the 4T's is kind of silly, but it stands for thrombocytopenia, timing of platelet decrease, thrombosis, and the last T is other causes of thrombocytopenia. And for each category, we will give points from 0 to 2 based off of the degree of severity. So for example, thrombocytopenia, if there is a greater than 50% fall in platelets and platelets counts end up being about 20,000 to or higher, that's the highest point that you could give. And it goes all the way to 0. So it's interesting to point out that the drop in platelet is more associated with HIT than the lowest possible platelet count itself. Timing, again, is important. Like I mentioned before, a clear onset between days 5 to 10 would be the highest possibility for HIT, or a drop in platelet less than 1 day if we know for sure that the patient had some exposure to heparin in the past. So for example, they were here earlier in the month for an admission. They had a cath lab procedure, and we know that they give heparin in cath lab, cabbage patients, things like that. For thrombosis, we get the most scores when there's new thrombosis or skin necrosis, of course, and it goes to 0 when we don't have any evidence of skin necrosis. And other causes of thrombocytopenia, like I mentioned, medications, devices, other disease progresses like sepsis. And at the very end, we add up all of our scores, and if your score is between 6 to 8, then that would give us a high probability of HIT of about 50%. And that's when we really want to start working up this patient to make sure that this is not something that we have to intervene immediately. So we have a patient with a super high probability of having HIT. We did all our calculation for the 4T score. So where do we go from here? So first thing first, make sure we discontinue all heparin-containing products. And a lot of time is not just the obvious heparin IV infusion or sub-Q 2 or 3 times a day. It's also the heparin fluid for arterial line, heparin flushes for catheters, things like that. And as I mentioned before, cath lab and during cabbage surgery, we use a huge amount of heparin. So make sure that our cardiologists, our CV surgeons are aware of the patient is getting worked up for HIT or has a very high risk of HIT. And at the very same time, we'll see labs being sent out. And you oftentimes hear the HIT panel or HIT antibody to detect an actual production of antibodies in the body to heparin, and also something called a serotonin release assay. These patients with high probability of HITs are required to be anticoagulated, even though before they could be on just DVT prophylaxis. but now they do need to be fully anticoagulated. So alternatives for heparin-containing products would be argatroban, bivalirudin, fondaparinux. And eventually, when platelets count is stabilized and the patient's not experiencing any issues with thrombosis, then we can transition them to a PO agents like warfarin or Xarelto or Eliquis. And it's usually a lengthy amount of time being on full anticoagulation for patients with confirmed HIT. Up to 3 months if they don't have any thrombosis, or 3 to 6 months if they have some sort of a clot resulted from HIT. So the confirmation labs for HIT, the turnaround time for these labs are usually up to a week. And so it's important that we follow up and determine whether the patient actually had HIT or not. And if HIT was the case, then we should document heparin as an allergy when our labs come back. So let's shift gears and talk about antiplatelets. These are agents that inhibit platelet aggregation through a lot of mechanisms, just like how anticoagulants have different mechanisms in terms of messing with the coagulation cascade. We often see antiplatelets for patients who are post-PCI to prevent stent thrombosis. Sometimes we'll see them in minor ischemic strokes, high-risk TIA, things like that. But the majority of time we'll see antiplatelets used in a lot of cardiac patients. And so our typical, when we hear dual antiplatelet therapy or DAPT, that usually means that it's aspirin in combination with another PO antiplatelet. So say Plavix, Brilinta, or Effient. And typically, patient would have to be on dual antiplatelet therapy for the first 12 months after getting a stent. After those first 12 months, a lot of times they'll get dropped down to just aspirin for lifelong therapy. Okay, so let's look at our antiplatelet agents. So I want to talk about our PO options first because they are a lot more common and we're probably more familiar with these agents. So first, aspirin. It is an inhibitor of thromboxane 2A platelet activation. Typical dosing for ACS, there are a lot of dosing regimens out there, but these are the typical dosing for our STEMIs, non-STEMI patients. With a loading dose of 325 milligram PO, and if the patient is unable to take aspirin PO, we have the option of giving 600 milligram rectally. Then the day after, the maintenance dose usually dropped down to 81 milligram daily. Aspirin is used either alone or in combination with one of the other 3 antiplatelets. And typically, we don't really have to hold aspirin before CABG if the patient's determined to be eligible to get CABG. But sometimes it's also up to the discretion of the surgeon as well. The other 3 medications, clopidogrel or Plavix, ticagrelor or Brilinta, or prasugrel or Effient, they all work the same way. They work at the P2Y12 receptors. So with Plavix, the typical loading dose is usually 300 to 600 milligram PO, and with the maintenance of 75 milligram daily. It is one of those medications that can be affected by genetic variables, and so in certain patient populations, they're actually not the best agent due to increased metabolism. And if we need to hold Plavix before a CABG, then it's usually held for 5 days. Ticagrelor dosing, loading dose is 180 milligram PO, maintenance dose is 90 milligram twice a day. And the quirks that come with it would be adenosine-induced dyspnea and bradycardia. And similar to Plavix, we'll have to hold it for at least 5 days before cabbage. For Effient or Prasugrel, the loading dose is 60 milligram and maintenance is 5 to 10 milligram daily. It works really well, very efficient, but it also comes with the highest risk of bleeding, and there are absolute contraindications for those with history of stroke or TIA, and it's usually not recommended for patients older than 75 years. And since it works so well, the typical recommendations for holding before cabbage is 7 days. Next, we have the IV forms for antiplatelets. First, I want to talk about Cangrelor. It is pretty much the IV form of the 3 antiplatelets, the 3 oral agents that we talked about earlier. It inhibits ADP-mediated platelet activation at the P2Y12 receptor. So pretty much this exact mechanism as Plavix, Effient, and Brilinta. It is a short half-life medication, and so it is utilized a lot when the patient is not able to take the PO antiplatelets because they are waiting to get a cabbage in a few days. So there are typically 2 different dosing strategies for Cangrelor. For PCI dosing, which is cath lab, the dose is 4 microgram per kilo per minute, and it's usually just for the duration of PCI or up to 2 hours, whichever duration is longer. When it is used as a bridging agent for cabbage, the dosing is a lot lower. It is 0.75 microgram per kilo per minute, and it can run for up to 7 days before the patient receives cabbage. Platelet function returns within about an hour of discontinuation of Cangrelor, and so usually we stop the drip between 1 to 6 hours before the surgery. Efdifibitide, or I would just call it Integralin because it's a tongue twister, works a little bit differently from Cangrelor and the other PO antiplatelets, and it's almost exclusively used for PCI purposes. The dose is usually 2 microgram per kilo per minute with a max of 15 milligram per hour for up to 18 to 24 hours after PCI. One thing to keep in mind is that it can cause acute profound thrombocytopenia, and platelet functions returns within 6 to 8 hours of discontinuation. So we do have to discontinue the drip several hours before any kind of invasive surgeries or procedure. And finally, I just want to throw in heparin and bivalirudin. We already talked about them in the anticoagulation section, but I just want to bring them up because they are also very common agents for PCI as well. So the last class of medication that I want to talk about today is fibrinolytics, namely alteplase and tenecteplase. Okay, let's bring up the coagulation cascade again, and its end product, which is a clot. So just as how our body has this whole cascade of pathways to create a clot to prevent further bleeding from traumas, it also has inhibitory processes to dissolve a clot, like plasmin. Fibrinolytics increase the conversion of plasminogen to plasmin, and plasmin in turn breaks down fibrin. And remember how we talked about anticoagulants do not dissolve clots. Well, fibrinolytics do just that. They do actually dissolve clots. So a lot of times you hear them being referred to as clot busters. So when are fibrinolytics usually used? Here at Hendrick, we use fibrinolytics mostly for acute ischemic strokes. In smaller hospitals without capability for PCI, we'll see that used for STEMI as well if PCI cannot be performed within 120 minutes. And very, very rarely we'll see fibrinolytics used in pulmonary embolism when the patient has hemodynamic instability. Sometimes we even push it during a cardiac arrest as well, with the suspicion that the patient might have a PE. And again, it binds to fibrin in a clot and converts plasminogen to plasmin. So if you ever observe a patient being evaluated for fibrinolytics in the ER, it is a lengthy list of inclusion and exclusion criteria, and all of that has to be done very quickly because time is brain. And so the eligibility to get fibrinolytics for a stroke would be the patient would have to be at least 18 years old with a clinical diagnosis of ischemic stroke causing neurological deficit. The general time of symptom onset has to be under 4.5 hours. A lot of time we'll use the 3-hour cutoff for a lot of patients, especially for those who are older than 80 years old, those with history of stroke, diabetes, any active anticoagulant use. So, for example, if someone is on warfarin and their INR is less than 1.7, sometimes they will get excluded even though they are subtherapeutic on warfarin. As far as contraindications, these are just a few of a very long list of contraindications. So obviously, any kind of intracranial hemorrhage would be an automatic exclusion for fibrinolytics. Any neurosurgery, head trauma, or stroke in the last 3 months. If a patient is an uncontrolled hypertensive patient, and of course this is a modifiable contraindication. If we can get their blood pressure down with medications, then maybe they will be eligible. If their platelets are under 100,000, if they are on warfarin, therapeutic with INR over 1.7, or if they are on any other oral anticoagulants, namely Xarelto or Eliquis, they are also excluded. First fibrinolytic that I want to talk about today is alteplase. So as you might have heard that we're moving from alteplase to tenecteplase or TNCase for ischemic stroke, and pretty much we're using tenecteplase for the other indications as well for the most part. But I do want to include this medication here in case you're going somewhere, and it's always good to know since it's still a very common fibrinolytics. Alteplase or TPA usually comes in a kit with the total dose of 100 milligram. One thing that I wanted to point out is that the max dose for ischemic stroke is 90 milligram. So that means that we never give the full dose, the full 100 milligram for anybody for ischemic stroke. It is not the case for PE, because for PE you can give the whole bottle over 2 hours, or with cardiac arrest with suspicion of a PE, we can give a bolus of half a bottle, which is 50 milligram over 2 minutes, and repeat another 50 milligram in 15 minutes. Nowadays at Hendrick, you probably see Antiplatelets used in other purposes, like for catheter clearance or cath flow. We usually give like a tiny 1 to 2 milligram from a small vial per lumen. Or if you're familiar with ECOS. So this is a procedure that is done in a cath lab, and it basically applies ultrasonic sound waves to break up the clots, and at the same time there is a catheter that applies Alteplase right onto the clot. So it is a more localized way of dissolving a clot instead of giving thrombolytics systemically. Let's talk about tenecteplase, or TNKs. So the mechanism of TNKs is also very similar to alteplase, but it is more fibrin specific and it is more resistant to the inhibitors that stop the plasminogen activation. It also has a slightly longer duration. And as I mentioned, TNKs is the preferred fibrinolytic for ischemic stroke at Hendrick. In terms of dosing, I want you to really memorize the dosing for ischemic stroke indication, which is the bolded parts on this slide, and in the next couple of slides we'll talk about we'll have some practice problems for ischemic stroke dosing as well to get you guys familiarized with this. So for ischemic stroke, the dose is 0.25 milligram per kilo IV push with a max of 25 milligram. So one thing to keep in mind is that the kits usually come in 50 milligram vial. So for the indication of ischemic stroke, the max that you'll ever give would be half a vial. After dilution, the solution concentration should be 5 milligram per mil. So remember that. I also wanted to include the dosing for pulmonary embolism or STEMI, and you don't have to memorize any of this, and it's actually included on a little yellow box on the lid of the kit as well. And I just want to include this here as a reference. So it's also weight-based, but the weights are usually presented as a range, and if you're between this weight and this weight, then you'll just do this flat dose. This is a picture of a kit for TNKs, and I also left a box of TNKs for education purposes with Paulita to help you guys familiarize with using tenecteplase. So basically it comes in a kit with the diluent, sterile water diluent, and the actual vial of the drug. Basically you just use the entire content of the diluent vial, dilute the drug in the other vial. Make sure you don't shake it very hard to mix it up, and pull out the necessary volume with the included syringe needle in the box. There's also instruction on the lid of the box, but it's pretty self-explanatory. And we administer a bolus of a tenecteplase over 5 seconds. The second one is 53 kilograms and the last patient is 110 kilograms. And I'll give you guys about 3 to 4 minutes to figure out the dose and as well as the volume to be administered to these patients. Okay, let's go over the answer for our dosing. And again, this slide will be included in your version at the very end of the presentation. So for the 85 kilo patient, the dose would be 85 kilos times 0.25 mg per kg, and that gives us 21.25 milligram. The volume is 5 milligram per mil, and so with 21.25 milligram, that will give us 4.25 milliliters. So that's the amount that you'll draw up. For a 53 kilo patient, the dose would be 53 kilos times 0.25 milligram per kilo, and that equals to 13.25 milligram. The volume would be 13.25 divided by 5, and that will give us 2.65 milliliters. Okay, and the last patient is actually a trick question. So the dose, as we calculate, would be 110 kilos times 0.25 milligram per kilogram, and that would give us 27.5 milligram. And so if you refer back to the last slide, our max dose is actually 25 milligram, and so our volume would actually be 5 milliliters, or half a vial. We're almost done. So lastly, I just want to touch on very briefly about bleeding management for patients who are on antithrombotics. And of course, I'll just focus on the pharmacologic options, because there are things like, blood transfusions and other things that we'll have to do, which are beyond the scope of this lecture. And lastly, I would like to touch on a little bit about reversal strategies for patients who are on blood thinners. And as we know, we come across these patients quite often who come in with a trauma or a head bleed, and they happen to be on blood thinners. Or we would have patients who require emergent surgery, and they are on any of the anticoagulants, antiplatelets. And the caveat here is that sometimes we think of these agents as the antidote for anticoagulants, antiplatelets, but please keep in mind that they don't stop the bleed, so we still have to manage the bleeding part, and of course our ABC as well. So the first agent is either rosizumab or Praxbine. So as the name suggests, it binds to Pradaxa or dabigatran. So basically when it binds to the dabigatran molecule, it inactivates it. For those who are on Eliquis and Xarelto, we often see Kcentra or 4-factor PCC. Kcentra is just the brand name. Or andexanet alpha. Andexanet alpha is a newer agent, and it directly binds to our drug molecules in activating them, while Kcentra provide coagulation factors. And we're reversing the effect of apixaban and rivaroxaban through supplementing the patient with more coagulation factors. At Hendrick, we only carry Kcentra, and so andexanet alpha is not available. It is very costly, and at the moment, I feel like there are not enough convincing data to have it in stock just yet. So for warfarin, a lot of time we think of it as a vitamin K antagonist, and it only makes sense to give vitamin K to a vitamin K antagonist to reverse their action, right? But vitamin K actually takes a really long time to actually kick in and reverse the whole process. And so in the acute phase, I actually prefer Kcentra, which is PCC, Or FFP. FFP also contains a lot of coagulation factors. So vitamin K would be given in conjunction to Kcentra, but it's not going to reverse warfarin right away like PCC or FFP. And one thing I want to bring up is that vitamin K in an acute bleeding patient on warfarin should be given IV and not sub-Q or IM. Any other route of administration other than IV provide very erratic absorption, so it's not going to do any good. For those who received TPA or TNKs and ended up developing a bleed, we have tranexamic acid or TXA or aminocaproic acid are our options. I think Hendrick really only carries TXA. Moving on to antiplatelets, especially those with HAB bleeds who are on antiplatelets. And so, as the name suggests, antiplatelets, we give platelets to reverse it. And sometimes you also see desmopressin being ordered as well. A lot of time, this would have to be at the discretion of the neurosurgeon. And finally, protamine for heparin and enoxaparin. So protamine is actually an anticoagulant, but when it binds to heparin, which is another anticoagulant, they kind of cancel each other out. It doesn't bind as well to enoxaparin as it does to heparin. The calculations for protamine is dependent of the dose of heparin and how much a patient is. For example, if it's an IV heparin, then we got to calculate the total units of heparin within the last 2 or 3 hours, and we make our dose calculation for protamine based off of that. And so this is kind of just a primer on what we do pharmacologically for a bleeding patient on anticoagulants, antiplatelets, and fibrinolytics. As we all know, there are a lot of other steps involved in dealing with a bleeding patient. That concludes my lecture today about all the blood thinners. I know it's a very long and comprehensive talk. If you have any questions or if you need me to clarify anything, please don't hesitate to reach out. And I apologize again for not being able to be here in person today. Thank you for your attention, and please call or email me if you ever need anything. I hope you guys enjoy the rest of the day.